Okay. Good evening, our moderator, sir, Soliha, sir. Good evening, Bauman, sir, Krishnada, and audience. Thanks a lot for giving me this opportunity to talk on a very important topic in the field of coronary artery disease. So I would like to share my screen. Is my screen visible here?
Yeah.
Yeah.
Okay. Goswami, sir, very good evening. Okay. Okay. So I have been given the topic of CT coronary calcium score versus treadmill test for prediction of obstructive CAD. So when we talk about investigating tool, we should know why we are selecting this investigating tool. And it depends on the selection depends on our purpose, whether our purpose is for diagnosis of obstructive CAD in symptomatic patients, or it is for screening of obstructive CAD in asymptomatic patients. Screening may be to identify a pre-existing CAD, or it can be needed to estimate the risk of future event related to coronary artery disease. First of all, I'll talk about diagnosis of obstructive CAD in symptomatic patients. So for diagnosis of obstructive CAD in symptomatic patients, first and foremost, the history is very much important. And depending on the symptomatology of the patient, we can classify angina or chest pain into three categories. First is typical angina, second is atypical or non-anginal chest pain. Whenever all three criteria of typical angina is fulfilled, like constrictive discomfort in front of chest or in neck, jaw, shoulder, arm, which is precipitated by physical exertion and which is relieved by rest or nitrate within 5 minutes. Whenever these three criteria are fulfilled, then we would say the chest pain to be of typical angina in origin. Whereas if only two criteria are fulfilled, then we would say it is atypical angina. Whereas if none of these three criteria are fulfilled, then we would term it as non-anginal chest pain. Basically, before approaching any investigative tool for diagnosis of coronary artery disease, we should understand the Bayes theorem. The Bayes theorem is the pretest likelihood of coronary artery disease in a population is it influences the post-test risk of having CAD. So we should be very careful in selecting investigative tool to avoid false positive as well as false negative result from that test. So the estimation of pre-test likelihood is very, very important before prescribing any investigation. Depending on the clinical likelihood, probability of the CAD, if we can choose our diagnostic tool, suppose the probability of CAD is very, very high. In that scenario, suppose the patient is having typical angina and is having multiple risk factors. In that scenario, we would rather advise invasive angiography to determine the therapeutic option for that particular patient. And on the other hand, if the pre-test likelihood is very, very low, suppose a very young female patient presenting with very localized precordial pain, that means there is very low clinical likelihood of obstructive CAD in that particular patient. We should not advise any diagnostic test, whether it can be invasive or it can be non-invasive. And we know that advising unnecessary diagnostic test may sometimes show false positive result and can lead to further chain of unnecessary investigations and can lead to unnecessary anxiety in the patients. It is the intermediate clinical likelihood category where this non-invasive test like CT coronary calcium scoring as well as treadmill test helps us much in further stratifying or diagnosing the patient. So this is the pre-test probability of CAD, which has been given by European Society of Cardiology. Basically, it is based on the pre-test probability criteria given by Diamond and Forrester, which was given at least 33 decades back, and that has been modified in this recent guideline, 19 guideline of chronic coronary syndrome by ESC, they have included dyspnea in this estimation of pretest probability. Dyspnea has been included as the clinical features. So here we can see that based on the age of the patient, based on the sex of the patient, whether male or female, and based on the clinical type of clinical picture, whether there is typical angina, atypical angina, or non-angina chest pain, or dyspnea, we can further stratify the probability of obstructive coronary artery disease. Here you can see the color coding. Any dark green are the patients, are the categories where there is high likelihood of obstructive CAD, whereas light green are the patients categories where there is intermediate likelihood of obstructive coronary artery disease. So any percentage in between 5 to 15% in this chart denotes the intermediate likelihood of obstructive CAD, and any and the percentage below 5% is termed as the low risk category or low risk pretest probability of CAD. So when we classify a particular patients based on the pretest probability, based on sex, age, and nature of symptom, we get this intermediate category where the percentage is around 5 to 15% of pretest clinical likelihood. In this particular category, we can further reclassify patients depending on the presence and absence of various features, clinical features. Suppose the patient in intermediate category has got normal exercise ECG, normal treadmill test, and or if we have advised coronary calcium scoring, if the calcium score is 0, that means there is very low likelihood of CAD in these patients, and we can avoid further testing, and we can avoid pharmacological therapies in this patient. Whereas if there is increased likelihood, like if there is a modifier of pretest probability, like risk factor, dyslipidemia, diabetes, hypertension, smoking, family history of cardiovascular disease, resting ECG changes, LV dysfunction suggestive of CAD, and abnormal exercise ECG or coronary calcium score more than 0, in that scenario, we can carefully judge whether any pharmacological intervention may benefit this category of patient. So when we talk about screening of obstructive CAD in asymptomatic patients, then basically our approach should be a bit different. Here, we would stick to non-invasive testing, with low risk. And what are the rationales for screening in any asymptomatic patients? Because we know that advanced obstructive CAD can exist with minimal or no symptom. Sometimes the first presentation of obstructive CAD can be life-threatening arrhythmia or sudden cardiac arrest or cardiovascular sudden cardiac death. So to avoid those kind of scenario, we can screen. The rationale for screening during the subclinical stages of disease is the hope that appropriate treatment may improve the prognosis. So with the hope of initiating a treatment which can improve the prognosis in a particular subset of patients, we can even screen for asymptomatic patients. Screening may be appropriate for persons in certain high-risk occupation, like pilots, bus drivers, when occurrence of any cardiac event, sudden occurrence of cardiac event may endanger lives of many people. Screening may be appropriate for individuals with higher perceived risk of coronary heart disease who are beginning an exercise program. So before beginning any exercise, before prescribing any exercise program, we can screen for a particular patient. Routine screening in asymptomatic diabetic patient is still controversial. So there are a lot of controversy regarding whether we should prescribe routinely treadmill test or coronary calcium score in asymptomatic diabetic patients. So further studies are needed for this category. Now, what are the criteria based on which our choice of screening test would depend? So if a patient can exercise stress test is like TMT is preferred, because it gives us many physiological informations. It can give us the idea about the exercise capacity of the patients and help in prescribing the exercise therapy. Exercise test is the most appropriate and useful test for persons who are at high risk of CAD. Calcium scoring is most helpful in patients who are at intermediate to borderline risk, with the presence of risk enhancing factors. So this particular category, intermediate or borderline risk, this category basically in all the recommendations, these are estimated by calculator. That calculator was derived from pool cohort. So depending on the calculation risk estimation of the 10 years, we can divide the risk category of a patient. Intermediate risk means any category between 7.5 to 20% of risk of major cardiovascular event in the next 10 years, and more than 20% event rate is high risk category. So we should know where not to use calcium scoring. Coronary artery calcium scoring should not be used in high-risk patients due to the likelihood of false negative test. We all know that all lesion, all atheromatous plaque cannot be calcified. So if there are high-risk factors in a particular patient, if there is definite angina, then we should avoid prescribing calcium scoring as it can give rise to false negative test. And in patients with familial hypercholesterolemia, those who are very young, those patients have non-calcified plaque with significant stenosis. So in those patients also, we can get false negative test. And then even in very high-risk patient with negative CT scan for CSE, there is very high event rate that is of 15 to 20% over the next few years. So in high-risk patient, we should avoid prescribing calcium scoring. We should use calcium scoring very judiciously in young patients, as I have already described. They can have non-calcified plaques. And in older patients, because in older patients, almost in females more than 70 years and males more than 60 years of age, they have extensive calcification without any obstructive CAD. So we should avoid prescribing in extremes of this category of these age groups. Let us come to some basics of these non-invasive testing. First of all, I'd like to discuss about treadmill test. The commonest protocol we use is the Bruce protocol, where there are different stages of 3 minutes each, and the speed increases with each stage, and the grade also, or the inclination of the treadmill also increases with each stage. The basic problem with Bruce protocol is that there is sudden jump of oxygen consumption in between these states. In this stage,
we may have to quicken up.
Oh yes, sir. So there are other protocols also. I would go into details here. So I would like to discuss what are the negative points with treadmill testing. We know that if there is baseline changes in the ECG like LVVB, LVH, WPW syndrome, or whether there is pacemaker in the patient, there is digoxin use, there is resting ST depression, then we can get false positive result, or the test can be inconclusive. So basic of calcium scoring, we all know that a CT scan is required for calcium scoring. It is non-contrast and it is triggered by ECG. It is a prospective acquisition of the scan. And the commonest quantification method is Agatston method. Based on the Agatston score, basically we can have an estimate of the plaque burden and the probability of significant CAD. If the Agatston score is 0, then we can say that there is no plaque and the probability of CAD is very low. And if the Agatston score is more than 400, then we can say that there is extensive atherosclerotic plaque and there is high likelihood of at least one significant coronary artery stenosis. So preparation of the patient is required. I wouldn't go into details. So here I would like to discuss about recommendation for use of CAC given in various recommendation like ACC, ESC recommendation. CAC calcium scoring is recommended for cardiovascular risk assessment in selected asymptomatic adult more than 40 years of age at intermediate risk by ACC AHA pool cohort risk calculator. So between the 7.5 19.9% of estimated risk, it is recommended. It is also recommended in selected adults with borderline elevated ASCVD risk, and it may serve as an arbiter of risk in this category. So why would we like to screen the patient in intermediate probability? to know whether any specific therapy like statin therapy or aspirin therapy will help these particular patients. So basically, if the probability is very low, less than 5%, then no pharmacotherapy is indicated, only lifestyle modification is indicated. If the probability is very high, then of course we used to use highest intensity statin with lifestyle modification. We all know that this is for primary prevention of CAD, of course. And if risk category is borderline or intermediate, in this particular category, coronary artery calcium scoring will help. If the CAC is 0 in this category, then we can avoid the prescribing statin in this group. If the CAC is between 1 to 99, or if the CACS is more than 100, then of course we can add the statin in our prescription with the discussion with the patient. Whether we should use aspirin for primary prophylaxis in primary prevention in this group? No, aspirin should not be used for primary prevention of ASCVD based on the calcium score. And aspirin in few. Okay, so when we compare with the coronary artery calcium score with HSCRP or HS-TROPI, it is seen that the 0 calcium score has a better negative risk prediction value than other markers like HSCRP or intima median thickness. So to conclude, these are some comparison regarding advantage of coronary artery calcium scoring and treadmill test. Advantage of CACS is that it can be performed in patients who cannot exercise. It is non-invasive and it is less time consuming. Coronary artery calcium scoring may be performed without any patient preparation, and patients do not need any beta blocker or nitroglycerin or any other medication, and they do not require iodinated contrast agent. Treadmill testing, of course, we know that it is inexpensive, it is widely available, it is more physiological, and no radiation is involved. The limitations on coronary artery calcium scoring is that the use of radiation, but it is very less nowadays. The cost, of course, it is more than treadmill test. High heart rate or irregular heart rate, we cannot prescribe coronary artery calcium scoring. And other non-vascular finding and incidental finding can give rise to anxiety in patients. Symptomatic patients, absence of CAC does not exclude obstructive CAD in non-calcified plaque. We have lack of randomized control trial, or all observations are from observational studies, or all evidences. And in treadmill, there are many limitations that if the patient are unable to exercise due to associated conditions like intermittent claudication, pulmonary disease, it is a drawback. And many patients fail to achieve 85% of THR and tests become inconclusive. Many drugs can interfere, like use of nitrate and beta blocker. And it highly depends on the pretest probability. And of course, we know that the assessment of treadmill test is observer dependent. Thank you. With that, I would like to conclude my topic.
Thank you, Rajesh. We can have a discussion later on because we are running out of time.
Yes, sir. Okay.
Thanks for the excellent presentation.
Thank you, sir.